morning, everyone, and thank you for joining in this very special Grand Rounds. Hoping that many more of you will be joining us today. I have the pleasure of introducing my friend and my partner, Rob Michler, who will talk to us about the surgical anatomical concerns of the mitral valve, RT valve, and LVOT. Now, I wanted to share with you a little bit about Rob, who was very humble and didn't want me to introduce him with much, but I actually wanted to do so. He received his undergraduate degree with magna cum laude honors from Harvard. Following that, completed his medical school at Dartmouth, and then moved to New York, to Columbia, where he did his residency in general surgery, fellowship in cardiothoracic surgery and transplantation. And after that, completed a chief residency in pediatric cardiothoracic surgery with someone who was, without any doubt, the #1 heart surgeon in the world at the time, Dr. Aldo Castañeda, at the Brighams and the Boston Children's Hospital. Robert Michler has had many accolades, many that come close to my career pathway too. He's chairman and founder of the Heart Care International, an organization that have provided pediatric heart surgery to many thousands of children in Latin America who had no access to pediatric surgery. In fact, in the Dominican Republic, is one of the few, perhaps the only physician that has received the highest honor from the president, which is the Order of Juan Pablo Duarte. He also, and I had the opportunity of being with him when he received this in 2017 in Moscow. He received the Vladimir Borakovsky Prize from the Ministry of Health for his accomplishments in cardiovascular surgery. Rob had a very impressive career, having traveled and having leadership roles at many institutions. For some time, he was the chairman of cardiothoracic surgery at Ohio State. Almost at that time, when he was a chairman, I actually joined the faculty there as director of cardiac imaging. Ended up coming to New York, and had not expected that a few years later I was going to be interviewing with him for my job here. And as you know, he has been the chairman of cardiothoracic surgery here at Montefiore now for over 12 years, and have really moved the department to the current situation where we are ranked, one of the top in the country. So, Rob, I know that not only you have had a tremendous career until now, but that you are still reaching the peak of your academic potentials.
Mario, thank you. That was more than generous, and I have to say that one of the real pleasures in my career has been serving as your partner in all that we have accomplished together, because as everyone on this Zoom knows, we need each other now more than ever through difficult times. But Mario and I both recognized that many years ago, and it's been a very pleasurable work life for me. So I thank you for that, Mario. Mario and I talked about what the topic today would be, and we both came on to this notion that it would be helpful for our colleagues in cardiology to have a sense of what the surgeon experiences from anatomic concerns in the operating room, and why things potentially can be problematic in the operating room. So the only way I could think of doing that is by actually taking you into the operating room and visually sharing with you operations that I've performed over the years, taken videos or photographs, and give you a feel for what it is that we experience. So let me begin by showing you this anatomic view. This to me is the most important slide of the talk today, and I'm going to show it a few times just to reorient you. But let me begin by showing you that here at the top is the opening of the right ventricle. Here is the left ventricle. You see that most of the trabeculations, muscular trabeculations, are at the apex. The papillary muscles do not insert into the septum. They insert onto the free wall, and you see them here. Obviously, the nice, delicate, long cords. Here you see the anterior leaflet of the mitral valve, and probably one of the most important features that I can show today is this hinge juncture between the anterior leaflet and the left and non-coronary leaflets of the aortic valve. As you can see, there's not much room here. This is a very filamentous, narrow band of tissue that becomes very important when a surgeon is performing a double valve replacement, aortic and mitral, or anything that one does in the left ventricular outflow tract. And these relationships are key. So again, the left coronary, the right coronary leaflet, here you see the orifice of the right coronary artery. Here's the right coronary artery coming up over the top. So when one is looking through the aortic valve, one will see the anterior, the backside of the anterior leaflet of the mitral valve, may even be able to see papillary muscles, and also this very important structure here, the ventricular septum. And you can see that in this situation there, that gives you a feel for how far away the right ventricle is. And this is where the bulge occurs in the condition of idiopathic hypertrophic subaortic stenosis. And you can see how the anterior leaflet elongation here or abnormality in the left ventricular outflow tract can give you systolic anterior motion. So this is another viewpoint from the top looking down, and you see the pulmonary valve and the pulmonary artery. The pulmonary valve is the only valve that can be surgically removed without entering any other chamber than its inflow chamber, the right ventricle. All the other valves are contiguous with one another. Here you see wedged between all three other valves, the aortic valve. In my estimation, this is not precise because this should be slightly rotated. The aortic valve leaflet should be slightly rotated counterclockwise. The left coronary ostium is generally right here, the right coronary ostium a little more anterior. Nevertheless, right, left, non, and if you open it up and you look down here during systole, you see very importantly the membranous septum, and I'll show this in the operating room, the membranous septum here. This is where the bundle of His comes down, and that's why in IHSS HOCM cases, one makes the incision beginning at the nadir of the right coronary, not all the way over in this direction, or one will get into the bundle or one of the bundle's branches. The other thing to note is that this is here, this is the territory of the bundle of His. You saw it here. Let's look down. This is where the bundle penetrates. You can see its markings from the tricuspid valve, where the surgeon is looking down from right to left in this situation. One can identify where the bundle is. Importantly, similarly from the mitral valve, and what I teach the residents is that the posterior medial papillary muscle, these muscle heads here, and their line where the anterior leaflet and the posterior leaflet meet, the PM will, in bad surgery, require a PM or pacemaker. So this line here runs directly towards the bundle of His. So one can actually injure the bundle or its branches in aortic valve, mitral valve, or tricuspid valve surgery. And those are important relationships to understand. So this is the operating room. So here on your left is the left leaflet. Here's the non-leaflet, and above is the right leaflet. You are standing
Dr. Michler, we're going to reconnect you. Latoya is on her way in to help you. It appears your Wi-Fi is not cooperating on your end. Yes, please come in.
Latoya,
Okay.
where should I go? Should I do this lecture closer to the Wi-Fi?
What?
I'm standing right under a Wi-Fi connection. Can you hear me?
Yes, we can hear you. Absolutely.
All right, should I screen share again?
Yes, please.
Okay, am I back?
Perfect. Yes, you are back.
I've decided to stand directly under a Wi-Fi. You can see the Wi-Fi over my right shoulder, so hopefully this is going to work.
Okay. I hope you have it.
This is the bundle that I mentioned, and if you see it here, it attaches to the backside of the mitral leaflet and extends right across the left ventricular outflow tract. And if we go into the operating room, here it is on video, and here's the left, the right, the retractor is up against the hypertrophied septum, and I am manipulating this accessory band of muscle so as to make sure there are no chordal attachments to it, that it isn't an accessory papillary muscle giving chordal tissue to the mitral valve. And here you see it being excised and freeing up that area. Now I'm placing a suture in the hypertrophied ventricular septum to pull it down. You can see, importantly, oh, excuse me. You can see that there is white band of tissue where the SAM has been pushing up against the left ventricular outflow tract and gives it that scarred appearance. Down below us is the anterior leaflet of the papillary muscle, and you can see it once this is excised. Now this suture is going into the septum, and where the retractor is up against the septum here, this is the nadir. The bundle of His runs in this direction. This is the first cut. We'll migrate over and cut a little more, but this is the initial cut to assess depth. Now, there's no way that a surgeon can see the ventricular septum here or where the right ventricular wall is, so it can be dangerous in this region if the surgeon obviously cuts too deep. And that's the importance of having strong echo images and strong discussions with our cardiology colleagues in order to assess what the appropriate depth is, and we can measure that depth. Let's go to another case and show the membranous septum well. And here you see the right cusp, the left cusp, and down here in this area, you're actually going to see, there's the hypertrophied septum, there's the membranous septum. You see how thin it is. This bulge here, although you would like to take that bulge out, there's the septum there, and the bundle. The forceps just ran along the bundle. But that big bulging septum here, although one would love to take that out, if one excises in that territory, one will in fact produce heart block. So these are the things that the surgeon must be aware of. And there you see nicely the membranous septum. It looks nice and thin. And so that is the area of caution. Now, this is an echo that shows SAM, obviously, the hypertrophied septum, and then the postoperative result. And this is, in my view, probably too excessive in terms of the amount of tissue that was removed, simply because one is too close to the interventricular septum in the right ventricle. A VSD is just a few millimeters away from being produced. But as one can begin to appreciate looking through the aortic valve, that one doesn't have more than just a narrow tunnel vision. So trying to excise a lot of septum has to be guided by careful measurements, knowing how thick the ventricular septum is, and being very cautious not to penetrate into the right ventricular outflow tract, because that in most cases is a lethal lesion. It's almost impossible to view where the VSD is except on echo. Looking through the aortic valve, one will never see it. Opening the right ventricular outflow tract and the right ventricle, one might see it, but it is a danger to be avoided. And this shows the initial cut and then maneuvers for the second cut. This is from the Mayo Clinic, and it shows pushing down on the right ventricle to create this bulge. Again, the surgeon is just looking through a narrow tract through the aortic valve. So the first cut is in this area, and in removing that first cut, one often sees the second cut a little bit better. But obviously, if this cut goes in this direction, as opposed to how the dotted line is demonstrated, one will enter the right ventricle. Some cases often require, not often, excuse me, on rare occasions, there is a mid-ventricular obstruction that needs to be approached through the aortic valve to get the subaortic portion, and then through the left ventricle through a ventriculotomy to reach up and get that area. And I wanted to try and take you into the operating room to see this. And this is the best image I could come up with, but let me walk you through it. This is a patient in whom I performed a surgical ventricular reconstruction. They had a huge aneurysm. You can see the thin-walled, out of focus left ventricle. You see all the scar tissue around. But look here, we're looking up from the apex towards the base of the heart. First thing we see is the free wall of the left ventricle here, and then the transition zone to the interventricular septum. The right ventricle is just where this retractor is. And then look here, we're looking at the posterior aspect of the anterior leaflet, okay? And here is the left coronary leaflet of the aortic valve. Here's the right coronary leaflet of the aortic valve. And you can see this hinge area, there's not a lot of room when a surgeon wants to do a double valve replacement. And if we're trying to take out ventricular septum, you can see that this area and the left-right relationships are inverted from the relationship that we see when we look through the aortic valve. So it can be quite treacherous trying to get that mid-ventricular muscle out in a case of IHSS through this incision. And again, let me just show you, pretend we're looking from the apex up, and here you see the anterior leaflet of the mitral valve. This is the back side. Here's the left coronary leaflet. You start to see the top of the right, and here's that ventricular septum. And look again now through this, but map the left and the right, and this area is where the muscular band is that would need to be resected. What about the left ventricular outflow tract when one desires to perform a valve-sparing aortic root? This is a condition in which the aortic valve leaflets are normal, but they are separated because of an aneurysm, as seen here, or as seen here in the operating room. And what's interesting here is that this patient had severe AI, an aneurysm, annular aortic ectasia, and this area was a near rupture area. You can see that this portion of the aorta is quite thinned out. So again, returning to this structure, how do we remove the aortic wall, remove the coronary buttons, preserve the aortic leaflets, and not enter the mitral valve, the left atrium, or the right ventricle, or the interventricular septum? So essentially, in a valve-sparing route, we're going to remove all of this aortic wall. We have to dissect down and get to the very base of the very nadir of all the leaflets circumferentially, because we need to put a graft that comes all the way down and touches and is sutured to this area here, to this area here. And just for trying to visualize what the surgeon sees, if you put your left hand here, your right hand here on this hinge mechanism, your left arm would be the remaining portion of the left leaflet. Your back would be the non-coronary leaflet. Your right arm would be the remainder of the right coronary leaflet. And your right shoulder would be the area of the bundle. So your body is encompassing the remainder of the aortic valve and left ventricular outflow tract. So let's go to the operating room and see what this could look like. I am going to, Latoya, just help me share again here. I want to, new share, yes, okay, here we go. Share this, okay, good. So here again, we're in the operating room and we are looking now at the right coronary orifice, the right coronary leaflet, non-coronary leaflet, left coronary leaflet, and the left would be here. This is all aneurysmal tissue, as you can tell, but the leaflets look essentially normal. So as we play this, we're excising the right coronary button because we have to sew this back onto a graft. And now we're dissecting the outside of the aorta. Here's down to the left atrium, and then we have to do the right ventricle without getting into the left atrium, the left ventricle. So this is very meticulous dissection, but if we don't do it, the graft won't sit down at the base. So again, the leaflet edges look quite normal. We're placing sutures to support the commissural posts of the aortic valve. And the left coronary ostium is down here. You can see it in this image here. So left, this is right. We're hoisting up all of these leaflets, and then we're going to place a graft around this in order to bring the leaflet edges together in a more normal position. So here we're placing sutures that are anchoring sutures at the nadir of all three leaflets. And these sutures must be carefully placed so that one does not enter the right ventricular outflow tract or grab the base of the non-coronary cusp in this situation. Here's the graft coming down. The commissural posts are resuspended inside this gel weave Valsalva graft. This is a Valsalva graft where this area bulges out to reproduce the sinuses of Valsalva. These sutures that were placed at the nadir of all three leaflets are then tied down, and we look inside and we have to reposition the commissural posts inside of the new aortic outflow tract. And then we sort of get a feel, we kind of test it. Are we doing a good job? Do the leaflets look like they're going to come back together again? We put a little saline there, and we can see that the saline does, in fact, tend to hold water. So that gives us a little bit of confidence that we're on the right track. You can see the leaflets coming together nicely. And then we have to suture up the remaining edge of the aorta that we have retained so that we can reposition the leaflets in their location. And once we do this for all three cusps, we then can look inside and see that we do, in fact, have what appears to be a nice apposition of the aortic valve and its new position. So all that remains now is to replace the right and left coronary buttons onto the graft. This is very important because we have to visualize exactly where the hole should be in the graft so as not to produce any kinking of the left coronary ostium. And there you can see how nicely it lies. And then we suture circumferentially the button that we have created for the left coronary ostium. We complete that, and these sutures have to be perfect because you're never going to see this again. This is behind the aortic graft. You'll be looking from the top down, and there's no way to rotate this to effectively place a suture in this location to stop any bleeding. We then measure again and place the right coronary over the top in a comfortable position so the right coronary does not kink. And then we just complete the anastomosis. And once the anastomosis to the aorta is completed, we consider it to be a completed operation. And in this case, the patient had absolutely no aortic insufficiency and an excellent outflow tract and was able to retain their aortic valve. So now let's return to the lecture. And this is a case that was done, a valve-sparing route in Boston. The patient had a complication, which was a dehiscence of their graft. And here at the base of the mitral valve, here's the left coronary, up here is the non-coronary. And this patient had a dehiscence of their graft and a fistula between the left ventricular outflow tract and the right atrium. This got worse over time, and the patient was referred to me for evaluation and correction with the hope that the aortic valve would not require replacement. And once we were in the operating room, we were able to perfectly identify the anatomy. We put a patch in this juncture. You can see here's the non-coronary leaflet. Here's the left coronary leaflet, the right coronary leaflet. There is the mitral valve below us. So this resulted in an excellent outcome for this patient who was actually markedly symptomatic with a significant left to right shunt. Now let's go into the operating room and take a look at what calcium looks like in the aortic valve. And here it is, heavy calcium deposits. There's the orifice of the right coronary. And we excise these heavy calcific branches, but these, and look there, a little debris came off. This is like wet sandpaper. This is how I describe it to patients. But we work hard to get a very clean edge and a meticulous clean edge. Here we're using what are bone rongeurs to pick away at this calcium. And in so doing, we are able to get a nice, fresh, clean edge. But all of this can result, and a little deeper from that is the bundle of His. And if we get too close to the bundle, obviously we can get into issues with conduction. Let's turn our attention to the mitral valve, where here you see the nice clean anterior leaflet, posterior leaflet, which takes up about 2/3 of the circumference. Here is the posterior medial commissure, and right in its line of sight is the bundle of His. We've already mentioned the non-coronary and left coronary cusps, very thin curtain of tissue here, and obviously the coronary artery and the coronary sinus. The circumflex is a danger point, especially in this area near the anterior lateral commissure because it runs closest. And in cases of reoperative mitral valve surgery, where one is replacing an already existing mitral valve, all of this tissue gets foreshortened because it gets very scarred in. So once you've taken out the prosthesis, one has to be very careful to reseat the valve and place the sutures in the old annulus, because if one goes outside of that annulus, and we're only talking a few millimeters here, if one goes outside of that annulus, one is at risk for injuring the circumflex coronary artery. As one looks through the open leaflets, one sees that there are many heads to both papillary muscles, and each papillary muscle provides cords to both the anterior and posterior leaflets. One of the most attractive pictures I find is this one of the normal mitral valve. And this is what we find in ischemic mitral regurgitation. The valve leaflets are normal, they appear normal, and the lesion, the disease, is a disease of the left ventricle. And obviously that has to be addressed to ensure that one achieves excellent competence of the mitral valve. I'm not going to go into ischemic mitral regurgitation and how we manage it, because I don't think it really addresses our principal topic of today. But what does is looking at some pathology. This is classic rheumatic disease. One sees the foreshortened cords, the furled up edges of the mitral valve leaflets, the thickening of the mitral valve leaflets. And this is a condition that challenges us all. This is mitral valve endocarditis. You can see the fleshy excrescences along the anterior leaflet right next to the sucker, and then the calcified infected anterior leaflet. Here we're placing sutures. I place sutures to mark different structures so that I can cleanly identify normal structure from abnormal structure. And the scissors are about to continue cutting in the region of the anterior lateral commissure. But obviously, all this tissue has to go, and it's the only way to get a curative condition in a patient with mitral valve endocarditis. And this nicely shows the clean edges that we've been able to excise, and then obviously the anterior lateral multiple heads papillary muscle and the posterior medial multiple heads of the papillary muscle. And at the end of the operation, it can look quite normal, and this patient fortunately did quite well. Another condition that we all see often on echo is mitral stenosis with excessive calcification, principally in the area of the posterior leaflet. And here you see two sutures placed along the anterior leaflet just to be able to help with exposure and to define the edges. And one then begins the slow, methodical process of excising here the anterior leaflet. You can see the extensive calcification. And then one is left with a very, very important decision. And this is a challenge, I think, for many surgeons because there has been a great deal of emphasis placed on trying to get clean this posterior region. As you can see, the anterior region looks quite nice. The question is, what does the surgeon do here? And if the surgeon begins to excise all of this calcified tissue, one is likely to have to place a pericardial patch in this entire area in order to prevent posterior rupture. And there's also the danger that in taking this out with bony rongeurs, one could get into the coronary sinus or coronary artery. So what I teach and what I've been doing for many years is I make an intraoperative assessment of how thick and how dense is this calcification and how brittle is it. So I will debride until I feel I have removed the brittle calcium. That prevents stroke, but the residual calcium does not interfere with ventricular function. So I make it a point to test this area by placing some sutures into the thickest areas to see if I can get a good pledget on the free wall of the atrium, bringing the other end through the calcium and making sure that that calcium allows for penetration of the suture and that I haven't dislodged any calcium. So that is my standard technique. I've employed it for a number of years now. This is what it looks like after I've taken the sutures. And here you can see along that posterior leaflet that we do indeed have good atrial tissue. We're not close to the coronary artery or coronary sinus. The other ends of the suture are coming out through the calcium, but the calcium is quite stable and I can get a large valve into that orifice. And there you see that valve placed in the orifice. Now, one of the more interesting things that we deal with, and for me, one of the most fun things I deal with is structural disease of the mitral valve, and in this example, ruptured cords of the mitral valve. I have a very methodical approach to the valve, and the most important thing is visualization and making sure that one can see all elements. So this is the setup for me. And let me just go through the anatomy. This is the anterior leaflet. Obviously, this is the posterior leaflet. This is P2. Here's the commissure between P1 and P2. And I take a silk suture and I place it around a cord that I know is a good cord and is going to stay on P1. I do the same thing for P3. I place a suture in the anterior leaflet, the posterior leaflet mid-portion to help me identify structure. And then I put annular sutures around the back. This pulls this area up so I can see the entire posterior leaflet with clarity. What this allows me to do is make a judgment of which type of mitral valve excision I'm going to do. Now, All of you have heard of the quadrangular resection. That's the original operation that is basically creating a box and cutting out all this tissue. I have not done this operation probably in a decade for a very specific reason. Two, it takes out too much tissue, in my opinion. And secondly, it requires compression sutures of the posterior annulus, which pushes forward. It pushes the annulus forward. And when you push the annulus forward, you run the risk of creating systolic anterior motion of the anterior leaflet of the mitral valve. So I think that's a bad thing. The next operation that we started doing was a quadrangular resection with a sliding plasty. The reason this is called a sliding plasty on each end is that it slides the leaflet up and then allows this point and this point to be brought into the middle, essentially eliminating that anterior deviation of the back wall of the left atrium. I do not do this for cases with a quadrangular resection, but I might do it in cases where I do a V-plasty. Simultaneously. And this is commonly seen in conditions of Barlow's disease, where there's excessive or redundant anterior and posterior leaflet tissue. Very important to make sure that one understands the height of the leaflets as well as the heights of the cords. And in this case, we know that the average height for the anterior leaflet is cords is about 24 millimeters, and for cords in the posterior leaflet is about 15 millimeters. And I actually use this caliper here to measure leaflet height. I then can create artificial cords out of Gore-Tex by using the precise measurement of leaflet height. I always create 3 cords, whether I'm going to use 3 or not, because it gives me the flexibility. And it's sutured to one papillary muscle head and or both papillary muscle heads, and then directly to the leaflet edges, most commonly the anterior leaflet edges. And this is what it looks like in the operating room, 3 cords on each papillary muscle head that will then be sutured directly to the anterior leaflet. And as you can see, I've already completed the butterfly repair of the posterior leaflet, as you see here with the sutures running down and the sliding portion of the butterfly excision. And this is the view of the sutures attached with Gore-Tex sutures to the leading edge of the anterior leaflet. And this is what it looks like in the operating room. Obviously, a Barlow's case with severe mitral regurgitation. I begin by assessing, as I told you before, the posterior leaflet. The anterior leaflet's completely hidden here under the retractor. I've drawn what I believe to be the right butterfly excision to reduce height appropriately. Here I'm using the calipers to measure the height I want. And then I excise the leaflet along the lines where I have drawn the edges. And this gives me the ability then to excise this whole area and visualize exactly what the posterior leaflets are going to look like following the excision. Most important thing is what we all were taught in carpentry class, and that is measure twice, cut once. And here I'm assessing, I'm cutting out a little excess of the P2 region close to P1 because I didn't think that that limb of P2 had the proper height. And now we need to put all this back together. And this edge becomes the new height of the posterior leaflet because the downstream, the lower portion, will get sutured against the annulus. And here you see me suturing now this to the annulus. Remember, the left and right limbs here were actually portions of the previous height for the whole posterior leaflet. So now this is finishing the completion of the repair, and that gives you a sense of the new leaflet height. I measure it, it's within appropriate standards. So now it's time to turn our attention to the anterior leaflet. Again, I identify the principal chords of the anterior leaflet on both the A1 and the A3 sides. I pull this forward to evaluate everything carefully. I then measure with a caliper the appropriate height, which is generally the height at A1 or A3, where the cords rarely elongate in Barlow's disease. Here, the sutures are going down to the anterior lateral papillary muscle. You see the three Gore-Tex cords that are going to be placed. This is the suture for the posterior medial papillary muscle. We have now the opportunity to place the Gore-Tex suture on the leading edge of the anterior leaflet at the desired height. We then measure. We do not downsize in Barlow's disease. This is a nice large ring. We then tie all those circumferential sutures down, and this is the repair as it looks in diastole. We then fill up the ventricle with saline, test our work, and of course the final decision is always based on the echocardiogram, and we use transesophageal echo in every single case. And here you can see in this patient there is no residual mitral regurgitation, and in the last image you saw excellent outflow from the left ventricular outflow tract. One of the things I think we should all be extremely proud of is that the use of cords was originated by Bob Frater here at Einstein Montefiore, and he published that work in 1983. And whenever I give talks nationally or internationally, I always refer to this, and I always call it, with great pride, the Einstein repair. So Mario, I'm going to close there. If there are any questions, I'm happy to answer them, but I hope that was helpful to people to get a sense of what we as surgeons encounter daily in the operating room and what our concerns are from an anatomic perspective, and also to share some of the limitations in our ability to see everything that we'd like to in 3 dimensions, but we need our echo colleagues to help define bridges, borders, and depths in order to place the sutures and make the incisions properly. Thank you for inviting me today, Mario, and I appreciate it very much.
Thank you, Rob. Apologies to everyone for the technical difficulty.
Mario, I think you're on mute.
I am not. Can you hear me?
No?
Yes, we can hear you.
Okay.
Okay, all right. Apologizing to everyone for the technical difficulties. This was an excellent overview of structural cardiac surgery. I have to make a comment on what you show there, and I think you're absolutely right. The success and the failure of structural interventions, whether they are percutaneous or they're surgical, depends not only on the skills of the interventional or the surgeon, which are extremely important, but also in the adequate pre-procedural selection, planning, and intra-procedural guidance. That is something that I learned very early in my career at the Cleveland Clinic, where we were involved in every single valvular surgery before and during and after the procedure. And I should say right now we have created a very robust team, and we have very robust technology. We have now state-of-the-art cardiac CT, 3D echo, 3D printing capabilities, and we have a group of people that have really mastered structural imaging, like Ethan Goldberg, Edwin Ho, and in the anesthesia side, Chris Tanaka, Johnny Left, and on CT now Leandro. So the cases that I've seen that have not yield optimal results at any place that I've been, at the Cleveland Clinic, at Mount Sinai, and here, I would say the vast majority of them, over 90%, have been inadequate characterization of the lesion before the procedure. Many cases that were judged to be degenerative mitral valve disease have been rheumatic heart disease. As you can see, for the surgeon, looking at the anatomy of an empty heart is not the same as looking at a heart that is full of blood and in motion like we do with echo. So it's essentially, it's paramount that all of this is done ahead of time, very carefully, and reviewed by a team of experts. So I am very confident that we have the skills here to do the interventions that are required. I have no doubts about that, and I think we are poised to continue to grow together as a very strong program. Any common questions from the audience? Please use your chat function. In the meantime, I will maybe ask another question to you, Rob. What do you think is the role these days of mechanical mitral valve replacement? Is it falling out of favor? Are we going to still being using mechanical valves 5 years from now?
Well, I do. I think the mechanical valve is such a terrific valve. It's a durable valve. I'm just hoping that we come up with alternatives for anticoagulation. To me, it is excellent in both the mitral and aortic positions. And this week alone, I did a reoperation on a patient in whom I initially planned to put in a biologic aortic valve because she had a biologic mitral. And her left ventricular outflow tract was very small. So that leaves me as the surgeon with a choice. Do I use an aortic valve that's mechanical that gives her a higher effective orifice area index to her body size, or do an extensive mitral curtain operation to enlarge the left ventricular outflow tract? And I elected to use a mechanical valve in that circumstance, which is a more straightforward operation and one that gives excellent results. But in the mitral position, I remain confident in mechanical mitral prostheses. And until I see freedom from degeneration at 20 years, I'm not going to shy away from using it, especially in the young population.
Thank you, Rob. I know that Asim is logged in, and obviously Asim is someone that has really brought the cooperation and the collaboration with CT surgery to a new level. The work that he is doing together with Mei Chao it's really bringing Montefiore to be among the leaders in a structural percutaneous intervention. That's a great example of collaboration between the two teams. Asim, I wonder if you have any comments or questions. In the meantime, I have one question here from Juan. Can you comment on your surgical approach to prevent PVL in mitral replacement in patients with severe MAC?
What does
perivalvular leaks? I guess perivalvular leaks. How do you prevent perivalvular leaks when you do a mitral valve replacement in patients with severe MAC?
Well, I think that's not been an issue using the technique that I described in my lecture. And that's an assessment of making sure that one has removed sufficient calcium to allow for appropriate seeding of the mitral valve in that condition. And there are rare occasions where one has to do extensive debridement and place a pericardial patch to assure that. But I do a lot of mitral valve surgery, and I do not encounter paravalvular leaks in MAC as a significant concern any longer. Mario, I see a question from Luigi.
Let's see. Yes, there's a question from Luigi here. When do you think, and if you think that NOAC will reach approval for use with mechanical valves? Know that Pradaxa failed, but other companies are trying. Any news?
I have no news, but that is something that in the cardiothoracic surgery network, we were really interested in trying to define a good study that would allow us to look at that. But at the present time, we just don't have it. I think that'll be at least a decade away. Maybe Azim has some information on that.
Well, one issue I think it's important to consider here for everyone who's managing patients that have mitral aortic replacement is that mechanical versus aortic versus mechanical mitral are completely different situations. I think the risk of thromboembolism with aortic mechanical valve is so low that I would feel very comfortable with using low-level anticoagulation. In some cases, quite frankly, when I was at Sinai working with Fuster, we managed patients without anticoagulants for people that for some reason could not tolerate them, just on dual antiplatelet therapy. So perhaps as a first step, if the Cardiothoracic Surgical Network would like to do a study, I would consider that you try with aortic valve replacement first, what I think is the low-hanging fruit. There's a comment from Azim. Great presentation, Rob. I completely agree about the importance of collaboration and the heart team approach to valvular heart disease. What are your thoughts on the future of transcatheter tricuspid valve intervention? I have to make a comment on that. I have worked with many great surgeons throughout my career. Early on, I worked a lot with Bruce Lytle at Cleveland Clinic. I know, Rob, you know who Bruce is. To me, he was one of the greatest mentors that I have early on. And I would tell you, the nightmare for every surgeon, the nightmare has always been tricuspid valve surgery. Correct me if I'm wrong. And the management for us is to manage those patients after tricuspid valve surgery, because you're kind of replacing one problem with another one. Yeah. That was my impression. But I'm curious to hear whether you think that transcatheter approaches will be different to surgical approaches here.
I think they probably will. The tricuspid valve is like operating on the tricuspid valve. What's unusual about it is the tricuspid valve is so easy to get to. It's readily accessible. It's easy to visualize the entire anatomy, but there are a number of features that make it less desirable. One is the fact that it's so close to the conduction system. The other is that the tissue in that region just isn't that strong. It's also very close to the right coronary artery. And probably most importantly, I don't think we really understand the a tricuspid regurgitation, when to intervene, how to manage patients after intervention. And so I'm hopeful that transcatheter interventions will take that away from surgeons, because it's never been fun for us to deal with that valve. And there honestly, there aren't a lot of very good repair options for the tricuspid valve other than an annuloplasty. The leaflet edges, the leaflets themselves are so diaphanous, they're so thin, the cords are so brittle. It's just not a valve that it was meant for surgical intervention.
Yeah, part of the issue here, I think, is, I mean, at least at the time when I was very active on this area, we were probably going a little bit late to repair replacement. And when you have somebody who had hepatic congestion, early liver failure, you know, the stress of surgery, and it can be a challenge. Many of these patients die of you know, bleeding complications or hepatic failure with the procedure. But, you know, probably most of them have already severe right ventricular dysfunction and other conditions beyond the tricuspid valve itself.
Yeah, and to me, a very different lesion is mitral disease with secondary tricuspid regurgitation versus isolated tricuspid regurgitation and tricuspid disease, whether that's from endocarditis or some other pathway. But we manage mitral stenosis with severe TR, or the rare occasions of mitral regurgitation with tricuspid regurgitation. That's a different lesion, because dealing with the left ventricle in those circumstances, as opposed to isolated right ventricular disease.
As a comment of the same, thank you, Rob. I wanted to share with everyone that the first transcatheter tricuspid replacement performed at Monty was done by Rob. So thank you for supporting the program and the innovation in this field.
That's what partnership is all about. Let me clarify that, because I think people will be confused. It was my patient that I referred to Azim for tricuspid valve replacement.
Well, thank you again, Rob. This was excellent. I'm also very excited about the new faculty that you're recruiting, some that are already on board and some that are very soon to be announced. I think our faculty will be thrilled when they found out the rejuvenation of the surgical program that we're going to be experiencing here. And we are hoping that we will be able to match in cardiology the support that will be necessary for all of you.
Well, there's never a concern about that. We're excited too, Mario, and thank you so much for all the support and the invitation today.
Thank you, everyone. Have a good day.
Bye.